Lecture 3, Suctioning and Mouth Care. This presentation will be delivered by Steve Simpson, an honorary lecturer at Salford University and an advanced critical care practitioner in Stockport, UK. So Steve, welcome, and I'm really looking forward to your presentation. Thank you.
Okay, thank you, Una. Yes, my name is Steve Simpson, advanced critical care practitioner in Stockport, and today I'm going to talk to you and give you a small PowerPoint presentation on oral care and suction and intensive care unit. Next slide. So learning objectives. So we need to understand the principles of oral care, maintaining normal oral flora and its impact in avoiding aspiration, which can cause ventilated associated pneumonias. To understand the indications for endotracheal suction, and identify correct suction devices and to check for accurate and safe suctioning. Next slide. So why do we need to provide suction and oral care to our ITU patients? Well, obviously, sedated patients are unable to clean their teeth and maintain dental hygiene. The ET tube that patients have disrupts normal mucus clearance. So our lungs produce mucus as a natural occurring defense mechanism against bacteria, and we cough and we clear that without really noticing in normal day life. The cilia hair in our bronchial tree move these secretions up, and we normally swallow these. Now, when patients have ET tubes in, this mechanism is disrupted. We cough and we clear secretions from deep into our lungs. Patients that have an ET tube are unable to generate a very strong cough and need nursing staff or medical staff to initiate this to clear secretions. Saliva is an important enzyme in our mouth. It inhibits bacterial growth, and maintaining good oral hygiene maintains the stimulation of saliva and prevents these organisms from growing. Normally, we have gram-negative organisms, gram-negative organisms replacing normally found gram-positive organisms in our mouth, and this can cause pneumonias. The ET tube and tracheostomy tubes have cuffs, and if we don't maintain good oral hygiene and oral care, secretions can gather at the back of the throat above the cuff and generate a pool of saliva and contaminated secretions, which can cause aspiration pneumonia. Next slide. So normally we normally clean our teeth once or twice a day. So good oral hygiene with a toothbrush removes plaque and debris, and it makes the mouth produce saliva, maintains the moisture and mucous membranes in our mouth, keeps our breath nice and fresh, and our generally mouth in good condition. Without toothbrushing, plaque can build up in our mouth, and biofilms which assist in the multiplication of bacteria. It's been proven in sort of clinical trials and a Cochrane review by Hugh et al. In 2016 that chlorhexidine as a mouth rinse or gel can reduce the risk of VAP, ventilated associated pneumonia, from about 24 to 18%, which is a significant reduction. Patients that develop ventilated associated pneumonias have prolonged ITU stays. Next slide. So what is a ventilated associated pneumonia? So a ventilator associated pneumonia can be defined as a pneumonia that occurs normally within 48 to 72 hours following endotracheal intubation. And this is the length of time it normally takes for sort of the bacteria to grow and sort of proliferate and sort of patients to aspirate if we don't maintain good oral care and suction. Like any infection, ventilator-associated pneumonia can cause serious complications, and it can extend length of stay and cost to the hospitals. Most studies show that ventilator-associated pneumonias are due to these following bacteria, most which are not normally present in our mouth. So maintaining good hygiene, maintaining saliva will help neutralize these harmful bacteria. Next slide. So before we do oral care, we need to be aware that the airway device that a patient has, either an endotracheal tube or tracheostomy, is a very important lifeline for the patient and to maintain their airway. And these devices are held in and secured normally by some tapes or securing devices, which we'll go through shortly. So as nurses, we need to be aware of the device that is holding the ET tube in or tracheostomy and the length of this ET tube. So we normally should document this, and this is normally seen at markings at the sort of the tip of the lips or at the teeth. We should be also aware of the difficulty of patient's airway. If the patient has had a difficult intubation, we need to know what sort of grade of view it was and whether additional equipment would be needed in emergency if their airway device became dislodged. We need to be aware of the patient's size, the length of the tube, and the date it was inserted. We need to obviously have a good overall look at the patient's mouth. ET tubes can cause damage to teeth. This can be caused on intubation or just with sort of daily, the presence of the ET tube with daily care. So we need to look for signs of damaged or missing or cracked teeth. Patients may have dentures and caps. We need to make sure that they are still there so we don't lose them in the back of the mouth or into the airway. And if patients have dentures, these are normally removed at the time of intubation. We need to keep an eye on the soft tissues, looking at the lips and the mucous membranes, making sure that there's no sort of pressure damage caused by either the ET tube or the tie that is holding the ET tube in situ. Next slide. So this is a slide showing the different types of devices and holders that patients can have with endotracheal tubes. Each device has positives and negatives, and we need to be aware of the limitations of these. If a patient is going to be prone, which we have prone many patients with COVID, protruding airway securing devices such as the anchor fast may inhibit us doing this and cause pressure areas. ET tapes, either Velcro or tape around the lips, can also sort of cut in and dig. So we need to be aware of the positives and negatives of all airway securing devices. And these need to be checked regularly during routine nursing care. We need to check that the device is holding the tube at the correct length, and as mentioned before, this needs to be documented in the nursing and medical notes. Next slide. So the endotracheal tube or the tracheostomy tubes that patients have are cuffed, and these cuffs sort of maintain a secure airway and help prevent sort of secretions going down from the back of the throat into the lungs, and also maintain a secure airway so we can positively pressure ventilate patients. As part of the routine checks and part of oral care, the cuff pressure check needs to be checked. Okay, and this is to maintain the cuff at the normal pressure so it doesn't cause any damage on sort of the membranes at the back of the throat and the airway, and also it maintains a good secure pressure so there's no air leaking. If on undertaking oral care or during normal nursing procedures, if we notice that there's any gurgling from the patient's mouth, there's any air leak, you can hear this audibly, or there's a change in the ventilation settings and drop in tidal volumes, there may be an air leak and the cuff might be deflated. Normal cuff pressures range between 20 and 30 centimetres of water, and devices can be seen such as the one I'm holding. Next slide. Suction. So for oral care and endotracheal suction, we need to make sure that we are aware of our suction devices and how they operate and at the correct pressure. So as part of your emergency checklists every day, the suction should be checked, it's working correctly. And for endotracheal bronchial suction, we should be setting the suction control at 150 millimeters of mercury or 20 kPa. We need to be also aware that there is emergency suction devices, and these operate slightly different. And these devices are normally taken with patients being transported around hospitals or to CT departments. So we need to be aware of how the suction works, how to correctly change the suction pressure so we don't cause any damage to the patient. Next slide. So oral suction. So oral suction has, normally most intensive care units will have a device called a Yanker sucker. This is a handheld suction device which we can suction oral secretions from the back of the patient's mouth. This pressure is slightly less than endotracheal suction, set at 5 to 10 kPa, and this is so we don't damage sort of delicate mucosa in the back of the mouth. We should be aware and that we shouldn't be prodding the Yanker suction too far down the back of someone's airway where we can actually see. And we need to make sure that once we have finished with the Yanker sucker, we need to clean and rinse with water, sterile saline, as your unit decides, to maintain the cleanliness of the apparatus. Next slide. So we mentioned before about cooled secretions. As you can see in this diagram, the endotracheal tube has got a cuff. This is sort of inflated just below the vocal cords, and secretions can quite easily sort of collect above the vocal cords at the back of the oral pharynx, and can become contaminated with bacteria and leading to ventilated-associated pneumonias. Most ET tubes now that we have for sort of intensive care patients have a subglottic port. This is a little suction port which we can suction above the ET cuff, so we can remove secretions from the back of the oral pharynx, preventing ventilated-associated pneumonias. Next slide. So after we've done oral care, we need to be aware that patients need, as we've mentioned before, tracheal suction to clean their airways. So why do we need to do tracheal suction? So as you're looking after your patient, you may be aware that they start to have noisy breathing. On auscultation with a stethoscope, they might have crackles, creps, wheezes, which could be secretions that are moving around in the airways. You may be able to feel these secretions moving if you place the hand on the patient's chest. This is called tactile phimosis. And we could also maybe see the secretions in the ET tube moving up and down with the ventilator breaths. We may notice that the patient's oxygen levels decrease and the patients may become more hypoxic. And this is as secretions may be blocking sort of upper airways, preventing gaseous exchange into the lower part of the lungs. Ventilator settings may change, tidal volumes, peak inspiratory pressures on the ventilators may increase as secretions prevent air reaching the bottom of the lungs. Excuse me. As part of active physio and lung recruitment, suction with active physio can help relieve atelectasis, which is sort of the lungs being sort of squashed and consolidated, which we get in pneumonia. And we can also use suctioning to give diagnostic procedures for non-directed bronchial lavage and sputum samples. Next slide. So with any nursing procedure, especially with patients' airway, if they're being ventilated, there are complications. So suction, not only are we removing secretions from the patient's mouth or airways, but we're also, as with suction, we are actually removing oxygen from the patient's lungs. So this can cause transient drops in saturations and hypoxia, and drops in SpO2 monitors. Ventilation difficulties, we might cause the patient to go into bronchospasm. We can drop their tidal volumes. Recurrent suctioning can cause trauma at the back of, obviously, the mouth, and as the suction catheter goes into the lungs, it can cause trauma on the carina, where the lungs bifurcate into the left and right lung. As we mentioned, bronchospasm, as patients move secretions, we can cause them to become irritated. We can drop the PEEP in the patient as we suck out the air, which causes atelectasis. Suction for patients that are awake or we are weaning can be a bit uncomfortable with deep coughing. It is a aerosol generating procedure, an AGP, and obviously with COVID we need to be aware that if we do disconnect the ventilator circuit to provide suction and open suction, this can cause aerosol generating procedure, causing virus displacement. Every time we are touching and accessing the ET tube or tracheostomy tube, there is potential for tube displacement, so we need to be aware of this at all times. But endotracheal suction is a necessary procedure for all patients with artificial airways. Most contraindications are relative to patients' risk of developing adverse reactions or worsening clinical condition as a result of the procedure. Therefore, there's no absolute contraindication. If a patient needs suction for any of the indications as mentioned, we need to undertake this procedure. Next slide. So, different types of airway suction. So, as just mentioned, we have opened or closed suction. And this can be either down an endotracheal tube, or it can be down a tracheostomy tube. So, what is open suction? So, open suction is when we get a suction catheter and we sort of disconnect the patient from the ventilator, and we insert the suction catheter into the ET tube or tracheostomy tube and apply suction. Closed suction or inline suction is when the suction catheter is part of the ventilator circuit, and we will talk about this next. So, is there a difference between suction between tracheostomy and endotracheal tubes? There is small differences in the suction tube size and length, what you need to be aware of. Also, tracheostomy tubes sometimes have fenestrations in the back of the tubes, and if we've got a fenestrated inner tube, we need to be aware that this can also prevent suction catheters being inserted smoothly into the patient's lungs. Next slide. So, closed or inline suction catheters is basically a suction catheter which is inside a sort of sterile membrane or sheath. These can be attached to the ventilator circuit, and so as we apply suction, we do not need to disconnect the patient from the ventilator. These can stay in situ. Each unit will have their own sort of time frame and policy on how often these inline suction catheters will need to be replaced. They are sterile, they are maintained in their own sterile sheath. As we said, there's no need to disconnect them from the ventilator, causing aerosol generated procedures, which is essential in COVID patients. There was a reduction in loss of PEEP, and maybe improvement in degrees in hypoxia if the patient is not disconnected from the ventilator. Most inline suction catheters come with a catheter mount and a little clip, so we can actually disconnect it from the ET tube, because they can become quite stuck onto the ET tube or tracheostomy tube, and a colourful sticker which highlights the day or the date and time that the patient has been put on a inline suction catheter. These need to be frequently changed because they can harbour infection, and we need to be aware that after any suction procedure we need to sort of clean the suction tubing. The inline suction tubing has a cleaning port, so once we have done safe suction on a patient, we can apply saline or water to flush the suction catheter. Next slide. So, an open tracheal suction procedure. Obviously, most patients will be sedated, but if they are not, then we would obviously need to consent for the patient. It is nice, even if a patient is sedated, to explain it to them just in case there is some awareness. We need to wash our hands, and we need to wear appropriate PPE, whether that is a face mask or FP3 mask, visor, goggles, gloves, and an apron. An open tracheal suction procedure is an aerosol generating procedure, so we need to be aware of this. Be aware of the baseline observations, tidal volume, saturations, heart rate, blood pressure, and we need to review this at the end of the procedure to see if there's any complications from suction. If the patient is very hypoxic or unstable, we can pre-oxygenate the patient for up to 3 minutes with 100% oxygen. We need to check the suction pressure, and it's set at the right level, as mentioned before, 20 kPa or 150 millimeters of mercury. Select the correct suction size catheter in length and diameter. Normally, a rule is if they have a size 8 ET tube, we can take 2 off that, so that equals 6 times 2 is 12. So a size 12 French suction catheter would be suitable for a size ET2 tube. So we sterilely open the suction catheter and attach the suction control end to the suction tubing. Okay, we can take the suction catheter out with our sort of dominant hand, and we can then disconnect the patient from the ventilator and slowly insert the catheter until we feel some resistance on the suction catheter. Suction catheters do also have markings on them, so we can actually look at the length of the catheter that needs to be inserted and the length of the ET tube, so we have a rough idea how long or how far the suction catheter needs to be inserted. Next slide. So slowly, obviously, excuse me, we can insert the suction catheter until we get some light resistance. We then apply suction and slowly withdraw the catheter, suctioning secretions as we go. We should not suction for more than 15 seconds. And then after the suction procedure is carried out, we need to reapply the ventilator tubing. Recheck the patient's observations and make sure that the patient is ventilating and oxygenating well. If there's any complications, then we should seek expert help immediately. If everything is stable, then we can then flush the suction catheter and store suction in appropriate clean receptacle. Before we need to carry out any more suction, we need to reassess the patient. Is further suction indicated? Suction is not a routine procedure. It should be carried out when required. We should record this in the patient's notes, and the amount and sort of quality of secretions can give information to the medical team if the patient is developing a pneumonia. Next slide. So closed or inline suction procedure is the same as I just described as for an open procedure, but obviously we do not need to disconnect the patient from the ventilator, and the suction catheter size and the length of the catheter should be selected appropriately at the time the patient is put onto the ventilator. After the suction procedure is carried out, likewise, we need to make sure the patient is ventilating and oxygenating well and everything is stable. And we need to then clean and flush the inline suction catheter with sterile water or saline as unit policy, and check the date and expiry of when the suction catheter needs to be replaced. Next slide. So after suction, most suction units have a disposable reciprocal, which we will need to change when it's full. Different units will have different unit protocols and policies on length of time that these can stay in situ. They obviously are full of secretions, bodily fluids, and can harbour bacteria, so this will vary from unit to unit. We need to dispose safely as a clinical waste policy, and make sure the receptacles are actually closed off with the plugs provided to prevent leakage. Next slide. So take-home message. Okay, good oral care can help reduce ventilated associated pneumonia. It's part of a good nursing assessment that we look at sort of the mouth from the lips and the mucous membranes and maintain good dental hygiene. Safe suction is an essential part of ventilated patients' care, so we need to be aware of how to use our suction equipment and where the emergency equipment is, and be aware of the correct and appropriate suction pressures. Oral care, like I say, suction is part of our daily checklists, and this should be checked at the beginning of every shift and maintained. During any suction procedure, if there's any concerns about the airway device or position or location of the patient as it shows any signs of desaturation or becoming unstable, then we should seek help very quickly. Next slide. And that's it. That's the end of the presentation.
Thank you, Steve. That was a very detailed and well explained delivery, really, of the procedures involved in mouth care and suctioning. And I think many nurses going into ICU for the first time will find that really beneficial and really very reassuring. And my questions are very practical in nature. So I imagine being a nurse either undertaking mouth care or suctioning for those first few times on an intubated patient would be quite anxiety provoking. And I wonder about the advice you would have to give them, for instance, in relation to what if the patient that I was looking after started to cough and gag on their ET tube when I'm undertaking their mouth care? What should I do?
Okay. So most patients that have endotracheal tubes will be sedated, and we need to keep patients sedated so they can tolerate sort of the endotracheal tube. Endotracheal tube is a very stimulating device and cause patients to cough and gag. And if nurses are undertaking suctioning and mouth care, this can also encourage patients to cough and gag. So if patients become distressed, they start to cough and gag, then we can consider increasing their sedation and taking their sedation score a little bit deeper, so they don't become too uncomfortable with the suctioning procedure.
Thanks, Steve. And you answered some of the other thoughts that were going through my head at the time, which is really good about, you know, how suctioning might be uncomfortable for a patient and the importance of communicating with the patient about the procedures before undertaking them and during them. And I really like the fact too that you explained how long we should suction a patient for. One of my other questions then around suctioning was, is there a difference in the suction device that we would use or the length of suctioning device that we would use for a tracheostomy tube or an ET tube, and why would that be important?
So a tracheostomy tube obviously is being inserted in the patient's trachea, which is, you know, a lot less distance until it reaches the carina. The carina is at the point where the lungs bifurcate to the left and right, And most suction devices, when inserted, will should just reach the carina. If we start to put suction devices too far into the patient's, can cause trauma and irritation, and can cause a little bit of bleeding and irritation to the upper airways. As I mentioned in my presentation, endotracheal tubes have markers on, so we know the length of the endotracheal tube, and most suction devices will have a length on their suction catheter. So normally a suction catheter should be just protruding maybe 1 centimetre outside of the endotracheal tube or the tracheostomy tube, so we're not causing too much irritation into the upper airways and the carina. So if a patient has an endotracheal tube, there are sort of long suction catheters, inline suction catheters. For patients with tracheostomies, there are shorter suction catheters or inline suction catheters, which are not as long. But ideally, we just need to be aware of how much of a catheter we're putting into a patient's airway, and aware that that can cause trauma if it's inserted too far. I suppose, like we mentioned in the presentation, we can slowly induce the suction catheter until we feel a little bit of resistance and have a look at the mark on the suction catheter, and that will give you an indication of the level that the suction catheter needs to be for ongoing suction. So you, instead of putting it in all the way, we know where we need to insert the catheter to.
Yeah, thanks, Steve. And I suppose from my experience as well of the closed suction catheters, some of the companies that provide those closed suction catheters provide them in shorter lengths, as you said there, for tracheostomy tubes, and longer lengths for AT tubes. And I suppose it's about the, thinking of the safety element and checking those suction systems before attaching them. So I guess if you attached a tracheostomy shorter suction catheter to an AT tube, it's not going to reach down far enough to be able to clear the secretions in a intubated patient. Yeah. And then my final question, you'll be glad to hear, is so what about changing of the AT tube tapes and the tracheostomy tapes or holders? How many people does that take for the procedure, and is there anything in particular nurses need to be careful about during that?
Yes, I mean, it is an important nursing activity that needs to be undertaken. The ET tapes can become moist and wet and sort of dig into the patient's mouth, or the other sort of anchor fast or securing devices can cause pressure problems. So we need to look at that. But obviously, their purpose is to maintain the position of an airway device. And without that airway device in the correct position, then a patient airway becomes untenable, and this might be caused life-threatening problems if the airway device becomes dislodged. So what I would advise to nurses is that it should be an experienced nurse or intensive care nurse helping with every sort of endotracheal tube tie or a tracheal tube change. They need to be aware that if it is a difficult airway, is there somebody around that can help them immediately if there is any concerns or problems. So these procedures are normally done in daytime. I wouldn't recommend doing them at night time when there's maybe lack of anaesthetists on the intensive care unit. And it should be carried out by a senior nurse with another nurse helping. So it's a two-person technique, but it needs a senior nurse to be helping and supervising with medical assistance available if or around if required.
That's great, Steve. Thank you. I know all of that advice will be really helpful and very reassuring to the nurses going into ICU to work. Thanks again for a really great talk.
I don't think nurses should worry about it. And suction and good oral care is essential, and they shouldn't worry about it. But they just need to sort of seek help and have some help around if they undertake this.
Yeah. Thank you.
Thank you very much, Jeanette.